try to spend a good amount of time on the recent update of the Bosniak classification. But a lot of this is going to be to really explain what the problems are in renal mass imaging. So this is a SAM, of course. You'll see little SAM alerts. Pay attention to those slides in particular. So what is the problem with the diagnosis and treatment of patients with small renal masses? Well, it turns out it's a radiology problem, and I'm going to try to suggest to you how we are trying to fix it. So, of course, our goal is to diagnose and make appropriate recommendations, and I urge you to include recommendations in your reports. I know that may be somewhat controversial, but I strongly believe that this is our purview, and I think it's important that we include recommendations. So I hope by the end of this talk you'll understand how and why kidney cancer is being overdiagnosed and overtreated today. I'm going to urge you to apply conservative approaches and to really focus on diagnosing benign disease. And finally, to apply the Bosniak classification version 2019 and understand its potential to contribute to this conservative approach. What we mean by conservative is doing less. We're conserving healthcare resources, if you will, through either active surveillance rather than surgery, or simply ignoring the lesions altogether. So if we go back 10 years ago now, in this particular paper where we were espousing that you needed to fully evaluate renal masses and do a full, what's called renal mass protocol CT. And all this is in your handout. So some of these slides I'm going to go through very quickly to try to save more time for some of the more complex slides. I think you all know how to do a renal mass protocol CT or a renal mass protocol MRI, where these are the basic requisite portions of a renal mass protocol MRI. And again, I hope you all already know this. And again, this is all in your handout and also on the Society of Abdominal Radiology Disease Focus Panel on Renal Cell Carcinoma website. So the problem begins with this so-called Incidentaloma conundrum, where we see these all the time and they're almost always benign, but unfortunately, renal cell carcinoma is diagnosed incidentally now, most commonly, and it's curable only when organ confined. So this drive to find cancer at an early stage is driving the evaluation of these renal lesions that are often unnecessary, costly, and cause a lot of anxiety. So first and foremost, when we encounter a lesion that's highly likely benign, we have to reduce imaging utilization. But we have this case, this small little renal lesion there. I mean, that's well less than a centimeter. What would you do with that case? Well, this is what it looks like just 6 months later. Okay, this is a aggressive papillary carcinoma type 2 that's already spread to the nodes. Now, this is a very uncommon subtype of papillary cell carcinoma, and fortunately it's uncommon to have this kind of aggressive approach. And if you correlate the percentage of metastatic disease at presentation with renal mass size, fortunately in T1A, i.e. 4 centimeters or less masses, the prevalence of metastatic disease presentation is on the order of 4 or 5%. And in my experience, it's probably even a little less, but nevertheless, these are the data. The size correlates with percentage of metastatic disease. I think that's been well known for many years. But because of this, we've been focusing on finding cancers at an early curable stage and treating them, but we're now wondering whether that's the right approach. Well, let's look at some overall cancer statistics in the United States. Kidney cancer or cancers of the renal pelvis are the 6th most common cancer in men and 8th most common cancer in women. So this is a relatively common cancer, okay? But if you look at mortality, it's nowhere on the map among the top 10. So there's this disconnect. We're finding cancers, but patients aren't dying of this disease. So that tells us something about whether, what really the meaning of having a kidney cancer is. But we've been aggressively treating them. This is just a study of patients with less than 10-year life expectancy, well over 66. This is patients of age 85 and older, and you can see that most patients are treated with a radical or partial nephrectomy. Okay, it's only until you start getting into patients over the age of 80 do you get active surveillance shown here in these black bars being used of any considerable amount. So back in 2015, we said, well, this idea that we got to do a renal mass protocol CT and MRI in everybody, it's probably not the right way to go. And in fact, the most common way renal masses present today is for a mass that's performed on an exam and which is really not completely characterized, okay? So we went through the rationale for saying, you know, let's take these cases and maybe leave them alone and have this conservative approach. So there are 5 basic reasons why we argued for that. The first is that, as you all know, most of these lesions are benign, including 20% of small solid ones, but despite that statistic, many are being resected. So we have to step back and say, well, you know, what is a renal mass? Now, the urologists look at a renal mass and they're thinking kidney cancer, okay? And that's their business. They want to make sure they treat kidney cancer at an organ-confined stage. But as radiologists, we need to be focused on any renal mass, any space-occupying lesion. So they could be pseudo-lesions, they could be non-neoplastic etiologies or neoplasms. And we need to make sure that we diagnose the non-neoplastic etiologies first. So you have this case, fairly straightforward, fear of pyuria, wedge-shaped abnormality with a lot of perinephric stranding. The more perinephric stranding you see, the more likely you're dealing with an inflammatory non-neoplastic etiology. This is a case of focal bacterial pyelonephritis, and here the history could be helpful. But the history may not be helpful. Okay? It's not uncommon for patient presented for hematuria, for other reasons, and there's a mass, and you got to look very carefully at the perinephric space to look for those subtle perinephric stranding so you can raise the possibility of focal bacterial pyelonephritis. So step back and think of the broad differential diagnosis of pseudo-lesions such as a column of Burton, hematomas, contusions, infections, vascular etiologies, an infarct, an aneurysm, a venous malformation, cysts, before you get to neoplasm. So any space-occupying abnormality is a renal mass, and I really want to emphasize that infections often will masquerade as tumors. So once you've into the neoplastic gamut, then the question is it a cancer, okay? And so we have to do a good job of make sure that we're not sending benign neoplasms to surgery. We have to exclude benign neoplasms. And unfortunately, we're doing a terrible job at that. Here's this 2019 study of almost 84,000 patients who underwent surgery for a mass thought to be malignant, and almost 10% of them were benign, and an estimated cost of $153 million. These are urologist-authored papers who claim that this is a significant economic burden, and to quote them, efforts to prospectively evaluate modalities for pretreatment identification, so that means is better radiology, should be further pursued. So we really have a problem as radiologists. We're not distinguishing benign from malignant disease properly. As a result, many benign lesions are being resected. And I believe that it's because we're underutilizing imaging and biopsy when a mass suspected of being cancer is detected. Now, which benign masses are we talking about? And we can go back many years ago to an original Mayo Clinic study which showed that of the benign lesions, they're typically oncocytomas and angiomyolipomas. And you say, you know, why are these being resected unnecessarily? Well, let's take the case of angiomyolipomas first. Now, this is a classic angiomyolipoma. You diagnose it by measuring -10 or less. Make sure you're measuring lesion region of interest, and make sure it's not calcified, because there are rare cases of renal cell carcinoma that have both fat and calcium. So if it's a non-calcified mass in an adult, you can make the diagnosis of a classic angiomyolipoma. But here's a case of this heterogeneous mass. The urologist is standing over you and saying, can I take this out? It looks like a renal cell, right? Can I take it out? No, you need to look for fat in every renal mass that you're about to treat. This has a tiny amount of fat. This is an angiomyolipoma with a very small amount of fat in it. It's a classic AML. It does have imageable fat, but you can't stop with an enhanced CT. No patient should go to surgery or ablation without some examination for fat. So why are classic AMLs being resected? Because they're not having that done, or using the wrong technique. You're not using thin sections. It should be no thicker than 3 millimeters. And you may miss it. We all miss stuff, but you can look very carefully, look for fat. And then there's this animal, okay, this hyperdense mass, and on MRI, it's T2 hypointense and enhancing. So hyperdense, T2 hypointense, enhancing. We said it's a renal cell carcinoma. This is an old case. Out it came, and it was a fat, poor angiomyolipoma. Oops. Patient should not have had a nephrectomy for this. What is this animal? This is a lesion that is hyperdense, enhancing. A light bulb should go off. Think fat, poor AML. Or T2 hypointense and enhancing. think fat poor AML. Could it be a papillary renal cell carcinoma? Yes. So how do you distinguish it? You biopsy it. Now, I don't have time to go into some really exciting advanced stuff using MRI, but here you're talking about a cancer versus a benign lesion. I want to be 100% certain. I want to biopsy those lesions. What about oncocytomas? Now, oncocytomas historically, there was years ago, it was thought, well, they could be malignant lesions. We now know they're not, they're benign, but we're having trouble distinguishing oncocytoma from an oncocytic renal cell carcinoma. And again, I don't have time to go through the details on this, but at the Brigham, we're just going to biopsy these things because you can make a diagnosis of an oncocytoma with reasonable certainty with an 18-gauge needle biopsy. Now, unfortunately, biopsy is very helpful but underutilized. Okay, here's a survey of over 1,000 AUA urologists, mostly private practice. A third would never perform a biopsy of a T1A renal mass. And it's hard to believe in this day and age. This is 2018 survey data. The academic urologists were more likely, but the authors of the paper really said that we're to their urologist colleagues here, I mean, what are we doing here? In light of 6,000 unnecessary surgeries annually, we're underutilizing this test. It's a good test. This is a large meta-analysis showing good diagnostic rate, good test characteristics. Not perfect for histologic subtype or for grade. We have room for improvement there, but it's a safe test. So you have a smattering of cases like this. You know, these are all solid enhancing lesions. We've ruled out fat. So, you know, we're not dealing with a classic AML. You know, how would you manage these? I hope what you would say is we would biopsy them. Why? Because that's an oncocytoma. That's a fat poor AML. That's a metanephroadenoma, a rare benign tumor, and that's a capsular leiomyoma. So these are all diagnosed with biopsy, saving this patient an operation and nephron loss. And I'll talk to you why that's important in a minute. So diagnosed benign entities. The second reason is that many small renal cell carcinomas are not aggressive. Only about 20 to 25% of them are aggressive. So it's not just the goal of diagnosing a cancer, it's determining which of the cancers that are actually going to limit one's lifespan, okay? And that's a really important point, particularly when you're dealing with an older patient. So this is a large study looking at the grade and aggressiveness, and you can see it's all related to size. I'll just summarize this, that 1/6 of 2 centimeter tumors, 1/4 of 3 centimeter tumors, and 1/3 of 5 centimeters are aggressive. So many tumors are not considered aggressive lesions. With a 10-year cancer-specific survival of 96% for indolent and 81% for aggressive lesions. So we have another diagnosis problem. We need to distinguish indolent from aggressive disease with imaging, if possible, and if not with imaging, with biopsy. And so that's another reason why biopsy is really being underutilized. But this is a larger problem. It's not necessarily an imaging-only problem. There's studies on urine biomarkers, on looking at the biopsy specimens, at molecular genetics. So there's a lot of work being done in this space. So with respect to biopsy, this is, we reviewed sort of the indications for a biopsy in our paper this year at AJR. It is now accepted and recommended when a malignant etiology is possible and where biopsy results may influence management decisions. This is fully embraced. I remember giving this talk years ago and people come up to me and say, but Dr. Silverman, my urologists just don't want to do a biopsy. They want to take them out. No longer the case, okay? The urology community, the AUA, ASCO, ACR, everybody's endorsed biopsy. And what are the goals? The goals are, as I said, to keep the benign masses from being unnecessarily resected and also to help select which treatment is best, surgery, ablation, or active surveillance. It's another reason to do a biopsy. So if you have a malignant result, you can put patients into different categories, if you will, an indolent category or an aggressive category, and that might dictate management. Surgery for aggressive disease, maybe watch indolent disease, and then you can put them into an intermediate category. This is just my schema, but what I've done is I've taken a mission group study from 2013 in which they actually stratified patients into indolent, which was chromophobe renal cells and grade 1 papillaries, intermediate, which was the low-grade clear cells, the grade 2 type 1s, and aggressive, type 2 papillary, like that case I showed you up top, or a high-grade renal cell, or urothelial, or sarcoma to it. And then maybe something like this might really wave the future of determining which patient should undergo which treatment strategy. So again, our goal is to try to diagnose indolent disease for which nothing is needed in selected patients. So the third reason to be conservative is that the treatments are costly, morbid, both procedure-related and long-term. And I just want to focus on the long-term morbidity. You're all familiar with, obviously, the risk of having an unnecessary nephrectomy. But the long-term results are, just to summarize, is that chronic kidney disease is an independent risk factor for death, cardiovascular events, and hospitalization. So you don't want to lose nephrons. It's a very important point. The fourth reason is that the treatments do not appear to be affecting our disease-specific survival, and that's really the ultimate goal. Most patients die of other diseases. So here's a graph where we put in the rate per 100,000 of renal cell carcinoma and the mortality between 1975, and this slide is 2015. And to summarize it, since the advent of CT, the incidence of RCC has doubled, but mortality has not changed. So despite us treating all these small cancers, we're not really affecting mortality. What are we doing? This is really the goal. The goal is to actually reduce mortality. What it means is that these small cancers never would cause any death. Here's a little more data to show that maybe the cancer incidence is plateauing, but again, there's little, if any, drop in mortality. And this is just an old slide just to point out that most patients die of non-cancer disease, cardiovascular disease. Of the cancer mortality, most is non-renal cell. Here's where RCC mortality is, way up here in the corner. Most patients die of things other than RCC. The fifth reason is that we now have a fair amount of data to say that we can watch them safely. This is a study of median follow-up of 67 months. And the data are quite good. The risk of watching these patients appears to be about 1 or 2%. So it's not a zero risk, but it's a low risk. Now let's talk about cystic masses and get to the Bosniak classification, because most masses are cystic. And if you look at the classification, these are the data accumulated over many years. You can see here that among the 2Fs, 3s, and 4s, a good many of them are going to be benign. So the problem is we're taking a lot of these patients to surgery when they shouldn't be taken to surgery for the reasons I just mentioned. So while it's widely used, there's specific problems that we really want to address. One is that this issue of the many benign renal masses are being unnecessarily treated. Cystic RCCs, like solid RCC, is overdiagnosed and overtreated. There's a tremendous amount of interreader variability. You think it's a 3, you think it's a 2F, and you think it's a 2. We're all over the place in this. There's also the data on malignancy rates per category all over the place, very variable. And we're not formally incorporating MRI and ultrasound. And it doesn't include all cystic masses. So these are problems that we want to address with this update classification. There was an effort from the SAR's RCC DFP and was published just a few months ago. So what we wanted to do is to modify the definitions to improve specificity, all right? We want to make sure that we say it's a cancer, it really is a cancer. So we had to try to put a larger proportion of masses into the lower classes, define the features, the terms fully, so that people are using the same language, adding MRI and to some extent ultrasound, and then adding every cystic mass, including those incompletely characterized. So let's briefly overview of this. I hope you're familiar with the basics of this, and so I can focus on the proposal changes. So a benign simple cyst, the difference here is that it was defined as a hairline smooth wall and no enhancement. But look at that lesion there. There's a little enhancing wall there. So the proposal defines hairline as 2 millimeters or less, and we allow enhancement in the wall of a simple cyst, so long as it's thin and smooth. Thin defined as 2 millimeters. And we can use ultrasound and MRI to diagnose a Bosniak 1 cyst. The Bosniak 2 lesion, the old criteria had thin and few, smooth septa, no enhancement, also allowed thin border forming calcification. The proposals defines, again, thin as 2 millimeters or less, few as 3 or less, and we allow enhancement in a Bosniak 2 and any calcification. The calcifications are really not predictive. The only caveat being that if you have a lot of calcification, we want to do an MRI to make sure we're not missing any enhancing components. And that's a Bosniak 2 cyst. okay? The other type of Bosniak 2 is the hyperdense cyst, okay? Here, we said it had to be 3 centimeters or smaller. The proposal now is there's an expanded list of Bosniak 2, okay? Now, I know this is complicated, but I'll try to go through them quickly. The first is the multiseptated cyst, as I just defined. The second is the hyperdense, homogeneously hyperdense, 70 or greater mass on a non-con CT. The third is a homogeneous, non-enhancing mass that measures over 20 at a renal mass protocol CT. It may have calcification of any type. A homogeneous mass on a non-con CT that measures 20 or less. That's the simple cystic perirenal mass. And then on a portal venous phase CT, a mass that measures up to 30 Hounsfield units, okay, can be considered a Bosniak 2 cyst, and a homogeneous low attenuation mass too small to characterize, okay? So that's all the masses you might see on a CT. We now can call those Bosniak 2 lesions. Bosniak 2 at MRI, again, is the septated cyst, as I mentioned. A homogeneous, markedly hyperintense on T2-weighted imaging, similar to CSF, like you might see in a lumbar spine MRI. Homogeneous mass markedly hyperintense on T1, so long as it's 2.5 times the normal parenchyma on a non-contest MRI, okay? What about 2F? 2F, the old definition, many, maybe minimally thick, perceived only enhancement, had to have a hyperdense cyst greater than 3 centimeters and thick calcium. So what do we do with that? And then we use these weird terms like indeterminate complex. Those words are out, okay? The proposal is the smooth minimally thick is 3 millimeters. It must enhance, or many, defined as 4 or more, smooth, thin, enhancing septa. And we're gonna MRI hyperdense cysts or apparent hyperdense cysts that are greater than 3 centimeters, and any mass with a thick calcification. We're going to call those Bosniak 2F cysts. So let's talk a little bit about these septa. Here's a case with 2 septa. It's a 2 because there are 3 or less and they're thin. And here's one with 5 septa. So that's a 2F because there are 4 or more and thin septa, okay? So remember, enhancing septa of a 2 must be thin and smooth. Okay? Now, enhancement's been redefined here, okay? We have a single definition. There's no distinction between perceived and measurable, okay? If it's unequivocally perceived, comparing non-con and contrast-enhanced images or on a subtraction MRI, or measurable, enhancement's now allowed in a Bosniak 1 and 2, but any feature must enhance to be in a 2F, 3, or 4. So both the definition and significance have been redefined. Now, what if you're talking about a small thing here? If it's not unequivocally visibly enhancing, measure it using the standard criteria for enhancement, 20 or Hounsfield units or greater, delta on a contrast-enhanced CT, or 15% increase on MRI. If it's not large enough and not clearly visible enhancing, the feature is non-enhancing, okay? So what about Bosniak 3s? Here, the definition is thick septa, 1 or more, and measurable enhancement. So the proposal says 1 or more enhancing thick, now defined as 4 millimeters or more, or enhancing irregular, defined as displaying 3 millimeters or less obtusely margined convex protrusions in walls or septa. That's a Bosniak 3 lesion. This one's a septated cyst. This one's a renal cell carcinoma. 50-50 chance right now based on the current data. So let's talk about the thin versus thick issue. 2 millimeters or less is a 1 or 2. 3 is a 2F. 4 is a 3, but they must enhance, right? Same with the septa. 2, 3, and 4. So just remember those 3 numbers. 2 is thin, 3 is minimally thick, and 4 is thick. Okay, what about a 4? Those have nodules, okay? And the proposal says 1 or more enhancing nodules, and we define a nodule as 4 millimeter or more convex protrusion or any size convex protrusion with acute margins. So let's understand a little bit better with a diagram here. So here we have nodules along the wall. It's a 3 if they're obtuse margins, and you measure it and they're less than 4 millimeters perpendicular to the wall. That's irregular thickening. Nodules can be any size if they're acute margin, like that little guy, or they have to be at least 4 millimeters in that perpendicular distance to be considered a nodule if the margins are obtuse. Okay, the same with along a septum, okay? So less than 4 okay, it's focal thickening or irregular thickening. And a nodule, it has to be 4 or more if it's obtuse margin, or any margin, any size if it's an acute margin. So again, you measure the perpendicular distance. So what we're trying to do here is to put this talk together from the standpoint of what are we doing with this classification. We're trying to improve specificity, okay? And we're doing that by allowing enhancement at 1s and 2s, as long as they're smooth and thin, septa or wall. It's required in 2F, 3s, or 4s. No feature that does not enhance can render the mass higher than a 2. And then there are caveats. So the heterogeneous non-enhancing mass at CT could be a 3 or a 4. So if it's heterogeneous, non-enhancing on CT, you've got to go and do more and do an MRI. Also, heterogeneously hyperintense on an unenhanced T1 fat saturated MRI is a 2F. Those are very typical lesions. They could be papillary cell carcinoma, so we're going to follow those. So we're applying this only to cystic masses, okay? Don't misdiagnose an aggressive necrotic RCC as an indolent cystic renal cell carcinoma. We spent a lot of time distinguishing necrosis from cyst. There's really no good definition, but try your best. Cysts are generally thin-walled, well-defined areas where necrosis is more ill-defined and more central. And before this, there'd never been a definition of a cystic mass. I mean, what do you apply the Bosniak to? What are you doing? So we defined it as a cystic mass containing approximately less than 25% enhancing tissue. And then what you can put at the end of your reports, and again, this is all in your handout, we can put this right in your structure report of what a 1 is, benign cysts requiring no follow-up, a 2, and there are 2 flavors, if you will, ones that we know are confident are cysts, and the others that we're not sure whether they're cysts or not, but we say they're likely benign. And the 2 Fs, we're talking about the fact that nearly all are indolent if they are malignant, but most of them are going to be benign. And we're going to follow them at 6 months, at 12 months, and then annually for a total 5 years, and then stop. 3s, intermediate probability, we're going to recommend urology consultation. 4s, the large majority of 4s are malignant, and we're going to recommend urology consultation for those. So now let's look about biopsy of cystic masses. The sensitivity for diagnosing malignancy is lower in the biopsy of cystic masses. Predictive value of no malignant cells is uncertain. And what's really gotten us away from biopsy is that we've been concerned over the years about subsequent changes in the mass's appearance from the biopsy itself rather than neoplastic change. But the biggest change that's really happened is that it seems to be safe to actively surveil Bosniak 3s. So if you're unsure if a patient has medical or surgical comorbidities, we're going to choose an active surveillance protocol rather than biopsy in those patients. Now, what about active surveillance? Who should we consider? Elderly, comorbidities, limited life expectancy. Which masses? Small ones, generally under 3 centimeters, 2 Fs, and then some 3s and 4s, of course, in patients with limited life expectancy. And then we don't really have a good way to follow these patients. An aggressive approach, we did look at every 3 months, maybe alternating CT MRI with ultrasound, and then every 6 months for 3 years, then every year. We don't really know what the right way is. And of course, biopsy in these patients are only going to be used for treatment candidates. When to intervene, the size threshold could be used, growth could be used, 3 to 5 millimeters have been talked about. We're going to maybe use biopsy, nomograms. There's nothing single that allows us to choose, but all can be used in combination. And then, of course, the patient may say, "Doc, I don't really feel comfortable following my cancer." So that's prompted many to suggest that we have to stop calling these cancers, but rather call them indolent lesions of epithelial origin, or IDLs for short. So in summary, what do the data show? They show that small renal cell carcinoma is overdiagnosed and overtreated without a survival benefit. Benign masses are treated unnecessarily and because they're being underdiagnosed. And the treatments may be harmful due to nephron loss. So what can we do? Diagnose benign disease, try to distinguish aggressive from indolent cancers, and contribute to conservative approaches. So I come back to this idea of utilizing imaging. We want to decrease the use of imaging of renal masses which are highly likely benign, which we're trying to do with the Bosniak classification, but actually increase the use of imaging and biopsy of renal masses suspected of being cancers prior to treatment. These are both conservative approaches. In the first hand, we're lowering imaging costs, and the second hand, we're lowering surgery costs, which are much greater than imaging costs. So that's why we're espousing this. So what specifically? Utilize renal mass protocol C-tumor to diagnose benign disease. Institute Bosniak version 2019. Biopsy small solid masses and treatment candidates to both diagnose benign disease and assess the need, whether to treat them. And institute active surveillance in patients with comorbidities and limited life expectancy. And maybe someday we'll formally change our terminology to IDLs. And with that, I thank you for your attention.